We have all heard people say that they have had COVID-19 and as a result are immune. But would vaccination boost that naturally acquired resistance? You're listening to Clinical Conversations from the NEJM group. I'm Joe Elia, and I'm joined by my co-host, Dr. Ali Raja, who is in the Department of Emergency Medicine at Mass General Hospital and a professor of emergency medicine at Harvard Medical School. We're about to interview Dr. Ronen Arbel on Zoom from Israel. His paper on the effectiveness of the Pfizer-BioNTech vaccine among the recovered has just been published in the New England Journal of Medicine. Dr. Arbel does health outcomes research at Clalit Health Services and lectures on health systems management at Ben-Gurion University of the Negev. Welcome, Dr. Arbel.
Thank you for having me. It's a great honor.
Thank you, Dr. Arbel. First of all, could you please, for our listeners, describe briefly the problem that you and the team investigated?
Okay, so if you look around the US CDC, European CDC, or NIA, or the UK, they all say each one has a different policy regarding when and how should I vaccinate the recovered subjects or patients from COVID-19. And they all said, we don't have any evidence. If we start with I think the most extreme is the United States CDC, said we don't have any evidence, so let's ignore. Actually, that's how we understand. We are ignoring your infection-induced immunity, and you're going to get vaccinated like all the others. The EU and all countries in the US have other policies. The UK has a different policy. Israel has a different policy, and they all said we don't have evidence. The only evidence actually that we found when we looked at this was a 500-600 patient study from Kentucky, which is probably not enough for significant evidence for the world. So we thought this is a very important clinical issue. We always look, what is the clinical question? I'm a physician, I have a patient who recovered. Should he get vaccinated? What will be the benefit? Or, of course, are there any safety issues? And that was the question. We had no clue what is the answer.
That makes perfect sense. And you mentioned the smaller study from Kentucky. It looks like you did this by reviewing the medical records of some 150,000 people in Israel who'd recovered from COVID-19. Is that right?
Yeah, we looked at all the patients in our healthcare organization that met the eligibility criteria. So that was the number. And for 9 months, so it's also long, it was for 9 months, not just for a couple of weeks, a couple of months. It was done in Kentucky.
And the Clalit organization, the medical records, you use their medical records, they insure or care for, I should say, about half the population in Israel. Is that correct?
Yes, 54%.
Okay.
And
all
most
right.
and about 2/3 of the patients above 65.
Okay. And so briefly, what did you find? What your primary and secondary findings, what were they?
So the primary finding, first of all, we saw an interaction with age. So that's why we reported by 2 age groups. And up to 65 years old, we saw 80%, about 80% reduction in reinfection rates. And the elderly, it was about 60% reduction.
In the older group.
Yeah, in the older group. And that's our main findings. What is very interesting, we think it's only secondary, but very interesting that one shot is enough. We didn't see any benefit, any additional protection from a second shot. It was our hypothesis, by the way. And it's very interesting that you said boost natural immunity. That's the way we look at it. I mean, you can see there are a lot of studies that show that infection-induced immunity is at least as good as vaccine-induced immunity. Of course, if you survive the COVID and all the problems of long COVID. Then the question, if it's similar to a primary vaccination, and it's really reasonable that one shot, it will act with some kind of booster, which was your first word, right? How do you boost a natural infection-induced immunity? So this is the biology that we saw. It was a nice study, and it's very similar to our results on the second vaccination. I think it's important because I think Eric Topol just wrote, why does the CDC ignore? It's like he had an early reading of our paper. Why does the CDC ignore natural immunity? You want your patients to get vaccine, but it has to make sense. You cannot say ignore it. We don't care that you're recovered. I mean, the science says it does matter, but still, the importance of study. You have a cover, you have a protection from your infection-induced immunity, but you can boost it, and you should boost it by a vaccination. But a single one is enough.
And this work was done mostly, maybe even exclusively, among those who recovered from the Delta variant. Is that right?
No. Exposure was to the Delta variant. We recovered from some of them recovered from the original, the wild type, and some from Alpha.
Thank you for clarifying.
Okay.
Yep.
Up to Delta, by the way, there were very little reinfections. What we see now, we saw in Delta many more reinfections, and you see in Omicron really much more reinfections. But up to Delta, the numbers were really, really small. So I think it was a very important to see what happens with the Delta.
So given the fact that this was an exposure of the Delta variant, any thoughts about what this might mean with Omicron?
I was sure that you'll ask. Of course, it's a great question. We don't have a study on that yet. It's probably too soon. But if we look at if we can learn from the past, which I'm not sure in COVID, right? You see that in Beta you didn't see any reinfections. In Delta you saw many more reinfections. In Omicron you see many more reinfections. Hopefully, we did not check this. We need to research this. We can hypothesize, I'm not sure what the results will be, that we'll have, I don't know if a similar effect, but an effect of the vaccine on your reinfection risk. But the basic reinfection risk, that's very clear. The basic reinfection risk is going higher and higher. It was higher in Delta, and it was much higher in Omicron. So if we assume, and we're not sure, if we assume that we have a similar effect, and since the reinfection rates, the basic reinfection rates are much higher, the absolute effect should be higher, assuming the same hazard ratio. But again, I cannot, we did not research this yet. So it's just an assumption. But we need to act all the time, and Israel is doing it very, you can see like the fourth vaccination and in uncertainty. I mean, we don't have evidence. We can just look at what we understand till now. That's why Israel decided on a second booster, right? A fourth vaccination, because the first booster was a huge success. Is the second booster a huge success? We actually have some results on this, and the ministry, our results are not published, but the Ministry of Health in Israel published. It's too soon to really tell. But the decision was made. You don't have time. I mean, do we have the luxury to wait to see if vaccination helps in Omicron? No, it's spreading like crazy.
That's a great point. So much of what public policy has been based on has had to be the data that we have available now, even though we're doing studies and there'll be more data in just a few weeks or months. You mentioned, Dr. Arbel, that the lack of a difference between one shot and two wasn't a huge surprise for you because it makes sense given the modeling. Were there any results that you did find surprising?
We actually did not know what will be the effect. We did not, I think 80% was probably higher than what we thought. We did not see, we did not expect that the older age group will have less of an effect. This age group interaction was discovered in the analysis, and we didn't know. We don't know when we go into the study what the results are. I must point here, it's very important to say this is not in any way funded by Pfizer or any other company. All of our researchers are totally unbiased, really, and I think it's very important. So we report what we find and don't look at what will the Pfizer. They may like the first part, they probably don't like the second part because you don't need a second vaccination or third vaccination. So we are very strict not to get industry funding for these studies, to make sure that I think it's important to ensure that there is not even of course, we're not unbiased, but there's not even a suspicion of bias. Okay, there's no way to, and so we can freely report what we see and be focused, and that's the advantage of our team. It has all the clinical physicians who are leading this effort in Israel. They also always push for the clinical question: should I vaccinate? How many vaccinations should I do? These are really important clinical questions. That's what we're trying to answer.
So let me actually ask you, Dr. Arbel. I'm an emergency physician. I see patients every day, many of whom have had COVID and are recovered. Some of those, fewer here in Massachusetts, but many still here and around the country, look at me and say, I just had COVID. I don't need to get vaccinated. What does this mean in terms of the conversations I have with them, or a primary care doctor or a pediatrician? What does this mean for the physicians who are actually seeing patients who have had COVID? What can we use this data to say?
So the easy answer is you recovered from COVID, you have some coverage, but you can improve it significantly, dramatically, but by one more vaccine. I think it's very simple.
Okay, well, we want to thank you, Dr. Arbel, for your time with us today.
Thank you. It's a great honor.
The pleasure is ours. But what's the next step? Are you going to be investigating Omicron and its effects?
So right now we're looking in, I think, some of the major clinical questions. Second booster, the Pfizer, especially the real world effectiveness of oral medication, especially Pfizer, especially in vaccinated, because all these studies have been done in unvaccinated patients. Most of these patients are vaccinated. This is a big question. We don't know from the RCTs. Is it working on vaccinated patients? We should have the results soon.
Those are exciting. That is such an important question.
That was our 282nd clinical conversation. We come to you from the NEJM group and the writers and editors of NEJM Journal Watch. Kristen Kelly is our executive producer. I'm Joe Elia.
And I'm Ali Raja. Thanks for listening.